Hello and welcome to Shock Talk. I'm Allison Shock.
And I'm Richard Shok.
We have conversations with people doing amazing things in the world of cardiac health, emergency medicine, and today we are super honored to have Jerry Overton. Jerry, I'm going to embarrass you for just a couple seconds and you correct me if I make any mistakes, but Jerry started off in EMS as a teenager. He eventually became one of the first 100 licensed paramedics in the state of Missouri. He then ran different as EMS chiefs in multiple cities, which we'll get into. He was named one of the 20 most influential leaders by GEMS, the Journal of Emergency Medical Services, has a couple Lifetime Achievement Awards from an AEMT and an REMT, and currently serves as the president, and I'm going to get this right, of the International Academies of Emergency Dispatch, IAED. Did I get that right, sir?
You got it exactly right. It's a privilege to be with you.
We're so excited to have you. I'd love to start by just going back. So you're a teenager in Missouri. How did you get started in EMS?
Well, back in Missouri, where I was born in Independence, Missouri, 3 doors up from where my parents lived, was the owner of owner of an ambulance company called Independence Ambulance, and they would bring their ambulances home because, back then, which we're not going to go into my age, but back then, a lot of times there wasn't even a station. So they would bring their ambulances home, and of course, just like every teenager of it was fascinated by a red light and a siren, they would leave their house with red lights and sirens. And so, I got to know them, and in fact, I went to school with one of them and decided to ask him if I could on a couple of calls, wrote on a couple of calls, and that was that.
So cool. So that was in high school, I assume, that you started?
Yes, that was back in high school, my high school days, and
What was
continued
the
into college.
and what was the training like? What was it like going out in a call compared to.
Training, Allison, training. I'm trying to consider. I don't think there was any training at that point in time. I'm not even too sure what type of equipment was on the ambulance at that point. I mean, I remember oxygen. I remember an emesis basin and not much else. Oh yeah, there was a stretcher.
Is it safe to say it was more transporting people to the place they need to be versus providing much care?
Well, back then also, you have to remember that the private ambulance companies, there were essentially 2 different kinds of EMS, or more than EMS. There was 2 different transport mechanisms. One was a lot of times fire departments in cities because there was nothing else, or private ambulance in cities because there was nothing else. And you also have to remember that many private services also is responsible for transporting dead bodies from funeral home to funeral homes. And
Oh,
so I can remember one time in which we were transporting a dead body and got a call and couldn't take it. So because remember, the dead body would pay, the non-dead body would not necessarily pay.
I never would have guessed that. That's crazy.
It was
So
crazy, but that was back a long time ago, thank goodness.
Getting into original training, at what point did you start, the first EMS classes? Did you have to start as an EMT, or did you jump right into paramedic program to become licensed, or at what point in your life did you take your first training in this area?
Being a resident of Missouri and being an EMS in Missouri, you were required to do an EMT course, which was essentially at that point in time, the DOT 80-hour course,
Hmm.
and get your EMT, and before you could begin begin any type of paramedic program. So was certified as an EMT, then I went back and got my paramedic license.
so then you served as the EMS chief in Kansas City?
I was the chief executive of the Metropolitan Ambulance Services Trust, which at that point in time was the not-for-profit trust that served Kansas City, Missouri, and several of the surrounding communities. And then I was asked or recruited, or not recruited, actually applied for, but was then recruited to become the first chief executive of the Richmond Ambulance Authority in Richmond, Virginia, which was at that time being served by, and ironically, by a private ambulance company that was having difficulty making finances. And the city decided enough was enough, that they would go with a public authority model and recruit a professional director with professional medical directors, and the Dr. Joe Ornato, who some of you may have heard of on this podcast, who is the medical director then of Richmond, Virginia, and Dr. Edward Rock, who I
Dr.
know
Rock.
all of you probably in this podcast has heard of. Um, Joe and Ed were my co-medical directors, and I was the director. So we were the first three to lead the Richmond EMS system.
Were you guys able to together form it the way you wanted, or were you handed a playbook that you were told you need to implement this?
We were giving a lot of freedom, frankly, by the city of Richmond and by the city manager of Richmond. I've got to give Robert Bob a shout out here because he was the city manager. In fact, at one point in time, he told me that he only wanted to see me in his office if there's any problems. So we were, which, and so Ed, Joe, and I really had a lot of latitude. The focus was, frankly, almost totally on patient care. Um, the system being a high performance EMS system, in a high performance EMS system, there's three basic tenets: excellent clinical care, response time standards, and economic efficiency. So as long as we were able to balance those 3 points on a triangle, we really didn't get involved with the city that much as far as city politics were concerned. And in fact, I can remember at one point in time, Robert Bob saying that during a budget crisis meeting or during a budget meeting in which someone was talking about everything wrong with the city or everything right with the city, he said there's only two things that are he said there are only two things that are going right in the city of Richmond right now. It's EMS and garbage collection. So I'm not sure how we fit with that. I think it was an interesting comparison, but yes, we had a lot of freedom to provide the very, very best in patient care, and that was what our objective was to provide the very best in patient care.
Gosh, that's what it should be. And unfortunately, it feels like sometimes, as you said, when politics gets involved, it becomes so much murkier. Correct me if I'm wrong, but you guys were one of the first to also implement with nurse triage within your EMS system as well out in Richmond?
Yeah, we were, this was much later on but I think one of the real tenets of the Richmond Ambulance Authority was to continue to be innovative, and that depending upon whether it was uh, new operational experiments or new clinical experiments, or in this case, a completely new program. We were the first in North America to do a couple of things. We were the first to implement a program called First Watch, which many of your viewers may have heard of. First Watch is
Mhm.
a adjunct to dispatch in which we're able to identify trends as far as syndromic surveillance is concerned, like flu, or at that point in time we were more interested in anthrax and terrorism events, but flu or outbreaks. So we've implemented the First Watch program, which is now widespread throughout the United States, and then we also implemented the first nurse program called Emergency Communication Nurse System, in which we were able to transfer calls to the nurses who were located in our dispatch center. Focus was on lower acuity calls and provide the lower acuity patient with a different experience.
With the nurse-based triage systems, were the nurses given kind of the ability to make their own judgment calls within protocols to uh, tell a patient to take medication at home or rest at home versus go to the hospital?
Yeah, so yeah, well, to explain it a little bit more in depth, there were certain codes or determinants through which we'll be talking about later, I'm sure, through the MPDS system, the medical priority dispatch system on the lower acuity side, that we were transferring to the nurse through a seamless transfer. And that those were proven lower acuity patients that would be safe to provide a alternative disposition, whether that alternative disposition would be a referral to a physician or making an appointment with a physician, alternative transportation to a clinic or a hospital, or yeah, self-help at home.
Did the ambulance authority also provide like taxi service or taxi rides for patients that need to go in on a lower acuity but not necessarily needing an ambulance, or was that like something that was still part of their responsibility?
No, I actually contracted out to with a couple of wheelchair companies. to be able to do this. This actually, interestingly enough, predates Lyft and Uber, where now systems are actually contracting with Uber and Lyft to provide these types of transports, these low acuity patients, and right to a doctor's appointment, which provides them a much better experience than sitting in an A&E or emergency department for hours on end.
Yeah, 100%. And all the
Yeah.
complications that can result with waiting and nosocomial infections while you're sitting in the hospital, and tying down the ER staff and
Mhm.
ambulances that, could otherwise be used for actual higher acuity emergencies. So that makes a lot of sense. And it certainly lessens the burden on a very busy system.
And then from the ambulance authority point of view, or from EMS point of view, the actual cost of that ride/transport is much less than the actual cost of responding an EMS unit and providing, essentially minimal care for a patient going to the hospital, then the ambulance having to experience wait time at the hospital before it can return to service.
When you had mentioned the earlier story of having to transport deceased folks and not being able to take care of active patients, we all know, of course, people call 911 because they're scared and they need help. But as everyone's saying, it's not always something that requires lights and sirens and ambulance. It's great that you guys were working to lessen that need from the ambulance, the EMTs, the paramedics to be able to be available and take care of those higher acuity patients.
Yeah, the real challenge we found in Richmond, and it's still a challenge in healthcare systems, is being able to provide the patient with alternative dispositions. I mean, simply because of the fact there's not that many clinics out there, or not that many mental health agencies out there that you can refer these patients to. And those have to be available to complete the systemic approach for that patient.
Mhm. Yeah, I have notes to go into some of the mental health stuff, as we go on, but to touch back onto Richmond, I know your work in Richmond then led you to a lot of international work.
Right. We were um, chosen by, I guess before that even, I mean, I was asked to go to Bosnia during the war and work to set up an EMS system in central Bosnia, which was essentially impossible because of the war zone. But I was able to provide some alternative solutions at that point in time. But that led to a partnership program that was funded through the United States government, USAID, um, and an affiliate association called the American International Health Alliance, AIHA, in which there were partnerships formed between EMS systems and either cities, or I can't call them systems in Russia, but cities in Russia or cities in what was called the new independent states in Central Asia. Um, we were asked in Richmond, we were asked to do a partnership program in Vladivostok, Russia, and then another one in um, Ashgabat, Turkmenistan. And so I was involved in setting those partnership programs up. And then, based on the successes we had in Ashgabat, also, I was asked to set up one in Tashkent, Uzbekistan. And these were great experiences for our paramedics because essentially they were paramedics training physicians in those locales. And so we were doing train the trainers, but our paramedics who were training their physicians to become EMS providers.
That's so fascinating. So they are physicians, but you're coming in to teach them kind of the implications of doing emergency medicine.
Yeah, you have to remember that, the physician training in many parts of the world does not equate to the physician training in the United States or Western Europe. And a lot of those countries have a plethora of physicians simply because of the fact they're going through a shortened training program, and they need alternative ways to provide care. And EMS, or
Mm.
being on an ambulance, is one of those ways.
It it's such a different scenario, but when I first started as a nurse, one of my very first patients, my first days, they fell and hit their head, and I realized I didn't know what to do. I was trained as a nurse to care for people, but dealing with an emergency was just such a different, type of care than anything I went through training for. So I actually ended up going through my EMT class after becoming a nurse simply to get that training. Um, and I it's really interesting to be able to really acknowledge that those skills are so specialized and that to be able to bring your resources, the experts to the places that need it is just so fantastic. So it seems like you said those were successes that you really were able to felt you were able to help those physicians and make a difference.
There was we never really were able to gather much data, but anecdotally, we do believe we made the difference. We did and still make a difference in those areas.
Well, I want to talk a little bit about dispatch. So, obviously you have an extensive history of, being leading EMS agencies, but it seems like in the last few decades of your career, you've really been focusing on dispatch systems. Is that correct?
Well, I mean, the fact is that, dispatch from our perspective, or even when I was in Richmond, dispatch was even in Kansas City, dispatch was pretty not was pretty was not really recognized as an important part of an EMS system. We've been talking about the field care, but what went on in dispatch system was dispatch center was somewhat secondary. It wasn't until 1991 when the concept of the chain of survival was published in Circulation and Resuscitation, and early access was made part of the chain of one of the four links of the chain of survival. But yeah, okay, maybe this is really important because
Hmm.
the original chain of survival had early access, early CPR, early defibrillation, and early advanced care. That was the four links. And early CPR, and early access and early CPR, at that early CPR back at that point in time, probably was more emphasized by both by like AHA and Red Cross training, where you
Hmm.
would go into a classroom and be taught CPR, not telephone CPR. And so it wasn't until, the chain of survival was published, and then there was an evolution into the emphasis on, hey, maybe we can do this on the telephone, that, dispatch began to really gain relevance as far as this role in the system.
So, in the earliest dispatch, I know you and I spoke a little bit before. Can you describe what dispatch sometimes looked like before there were regulations and protocols?
Well, I mean, it really was more or less, you know, like a call taker or an operator taking a call and maybe asking two or three questions and dispatching the ambulance. I mean, that was essentially it. Training would be minimal back then. I'll stress the word then, back then. And there were situations or centers or call taking places, whatever you want to call them back then. I don't call them dispatch centers there. That if someone got hurt in the field, well, we put them in dispatch until they healed, and then put them back out on the field.
Hmm.
So I think the evolution of modern dispatch really began, in the late '80s when the first protocols were developed and then became adapted or adopted, whichever term you prefer, to the dispatch center. So it's been an evolution, that not necessarily a revolution, uh, though I would refer to it have been a revolution that happened overnight.
So it's taken multiple iterations and really some evidence to show the benefit of having basically a call taker that's able to collect information and send somebody to the scene versus now being able to provide instructions. And then we've seen multiple iterations since then of now being able to provide telephone CPR, and then now we're looking at the future forward of how to actually get AEDs into the hands of people that are on scene of emergency medical calls before EMS arrives. And um, what is your take on kind of where the next steps of emergency medical dispatching is to be in the future, 5, 10 years from now?
It's an interesting question, Rich, and I'm not too sure I know exactly the answer. The fact of the matter is if we look at this as an evolution, I think if making sure that we're getting it right when the telephone rings is incredibly important.
Hmm.
And the more we can have an evidence base as far as the initial questions are concerned, the better off we're going to be. And the reason I say that is for a couple of reasons. First off, we do need to identify the cardiac arrest patient as quickly as possible. I mean, that's a given. The quicker we could get hands on chest, the quicker we recognize that patient, the quicker we get hands on chest. Study after study after study has shown that the patient is more likely to have a positive outcome. Return on spontaneous circulation happens quicker. and that the patient's got a better chance of a long-term outcome. So that's one reason. I think the second reason is that we don't talk about very much is the fact that, cardiac arrest patients are typically in any system only 2.5% of the total patient population.
Yeah.
We need to make sure we're getting it right on the other 97.5%. And the reason that's important is systems today have limited resources. I mean, the fact is, I don't know any system that has too much money or has too many paramedics. Um, and if we can ensure that we're triaging correctly in the dispatch center by using evidence-based protocols, the fact is then that we can save the valuable resources for the cardiac arrest patient and dispatch perhaps a lesser staffed or lesser equipped vehicle for the lower acuity calls and do that safely. It goes back to the question you asked about nurse triage a while ago. That's nurse triage is one answer, but ensuring that even on the lower acuity calls, patients that need to be transported, then we're using the correct resource to be able to do that and holding back the more advanced resources for those patients with higher acuity. So this is kind of a long answer to your question, and I know you asked me where I think we're going in the future. I do remember the root of your question, Rich. Um, but the fact is that gathering that evidence on the lower acuity patients has been difficult. We're getting it, but it's been difficult, so that we can ensure that we're safely providing the lower acuity patients an experience eh, that meets their need, and then saving the resources. So when we look into the future, then I think we're looking at more and more nurse triage programs that can provide different levels of care for the lower acuity patients. Maybe, in the future, I'm optimistic that maybe some of these patients aren't necessarily the lowest acuity. The question is they may be of moderate acuity, but the fact is they don't need to go to a hospital emergency room. I keep saying A&E. The reason I keep saying that is I have a lot of projects in the UK, and
Mhm.
I deal with A&Es in the UK and emergency rooms in the US.
Mhm.
Um, so that's the same thing. So I think the future is how do we ensure that we're providing the best care to every single patient every single time? I look at this more as a EMS as not necessarily EMS. I look at more as we're providing out of hospital care. That an EMS agency today is really its own mini healthcare system. It's taking high acuity callers, it's taking lower acuity callers. It's providing high acuity care and low acuity care. And it's providing high acuity experiences and lower acuity experiences to the patient. From the time that the input is done at the call taking to the output, whether that output is admitted to a hospital, whether that output is some type of a clinic, whether that output is a mental health clinic, whether a hospital, where it's a physician appointment, providing that is going to be more and more important because as we're seeing the trends right now for the future. The trends for the future is that more and more lower acuity patients are calling 911 as a
Mhm.
percentage of the total calls. Back when Allison was referring to my early days, I could say that probably 75 to 80% of the patients who would call the 7-digit number, which then transformed into 911, they were high acuity.
Mhm.
We have data now, evidence-based data now, that shows that that is absolutely flipped. We've
Hmm.
got data from Niagara, from other systems in Canada, systems of the United States that show that the higher acuity patients at most may make up 25%, not 75% of the total call volume.
Mhm.
So providing the total patient experience is, I think, one place we need to go. Now, you haven't asked me about AI, and I'm sure you will, so I'll go ahead and I'm sure I'll go ahead and address that. Um, AI on the front end is incredibly difficult because when we're looking at a patient or a caller, they're all over the map when they see an emergency or when they're experiencing any type of an acuity level. And to be able to capture that in an AI format it's just difficult to figure it out because of the fact, if you see someone falling right there on that rug in front of you, and the question becomes why they fall, or do they need a high acuity response because it's a cardiac arrest, or do they trip over the edge of that table that I'm looking at and are going to get right back up
Hmm.
after a few minutes, after a few seconds? Um, so when that caller says, okay, that's been a fall, then we need to make sure that we're providing an assessment that is accurate to be able to send the right resource. Now, where the use of AI, I think, is being implemented is in two different areas. One is simulation training for the call takers, because
Mhm.
we can simulate a call coming in and then interface that with a very real call taker response. So this could be used for education on the front end or continuing education, either one. The second use is in quality improvement. And that quality, because of the fact that, the answer is once we get past, okay, tell me what happened. Essentially, the questions are binary answers, yes, no, or a deviation of that. And that's relatively easy to, um, I think, work with an AI provider to provide a quick, rather than a call taker or a QI, more like a QI manager having to listen to a call for 5 or 6 minutes, running that through AIQI or QIAI, whichever way you put it, um, is going to be a lot quicker and just as accurate. So I think there's applications for AI. I see that for the future. And that I think can help alleviate some of the staffing shortages that we have in our comm centers.
It seems to me that that a lot of the technology that dispatch centers use tends to lag behind what the rest of the technology community is using by 5 to 10 years or so. For example, text messaging to 911 only became available a couple years ago, and that's something that has been utilized for probably the past 20 years or so. What about video? Would video be something that's helpful for the dispatchers to be able to connect with a caller and be able to see a patient and help to provide an assessment as to what is going on the scene? And are there any dispatch centers that you know of that are using video to be able to help perform that assessment?
Actually, a video option with our system. So the answer is yes. I think there's somewhat of a reticence to use a video, or because we've got to make sure we understand what the impact is on the dispatcher or the call taker. Um,
Mm.
you know, right now we're probably experimenting. Besides the medical part of dispatch, the medical part, we also have a fire protocol and a police protocol, and we're probably more likely to implement it quicker on the police side, simply because of the fact that most of the calls that police get are not necessarily for response or for a report. Someone's broken into my house or someone stole my bicycle. Well, that's not going to impact the psychological. That's not going to have a psychological impact on the call taker. A call taker is operating. You have to remember, a call taker right now is operating in a non-visual environment, and once you turn that into a visual environment, we're not real clear what type of psychological impact that's actually going to have. For them
Mm.
to actually see what has happened to that patient, you know, um, we really need a lot more knowledge about that. I can remember I was in Birmingham, England. No, I'm sorry, Manchester, England, after the Manchester Arena bombing, like a week later, in which
Mm.
that bombing, if you remember, was a horrible, horrible bombing of an arena of a rock concert of which children were attending. And I can tell you this, that talking to the call takers there at that point in time, they were very happy they didn't have to see video
Mhm.
of what they were looking at. Because to a call taker that I talked to, when they went home that night and actually saw the news, most of them had to have counseling because they're not
Mm.
used to this type of situation. So I think from a call taker perspective, I think that once we transition into the maybe telephone CPR or the instructions and post-dispatch instructions, that would be a good point to be able to turn it on. Be able to make sure we've got placement of hands correctly on a CPR patient, making sure that the tourniquet is being applied for a patient with hemorrhage. Um, I'm not sure about childbirth yet, maybe, but I think there's applications that we are looking at. But yes, to answer your question, we do have a couple of video providers. We are using video for our nurse program, ECNS program. So it's definitely here. It's just how do we use it in the best way possible for both the patient and the call taker?
Mhm.
Yeah, that makes a lot of sense. I know we didn't necessarily discuss this, ahead of time, but the the strain it takes on the call taker because they are helping them until EMS arrives, but then they often don't get that closure of what has happened after EMS takes over. Um, is that a strain that you see often on your call takers?
Absolutely. And I think the fact that, when we consider a lot of EMS systems do grand rounds, as far as, you know, looking at complex patients, having the call taker in the room when that ground round occurs with the paramedic, with the physician, so that they understand what that outcome is or what impact they had on the outcome, I think is incredibly important. Yeah, and absolutely, you're absolutely correct. I mean, mental health has to be a part of any agency's program, not only for the paramedic, but also for the call taker.
Mhm.
Mhm. Gosh. Well, I would love to talk a little bit more about what you guys are doing with IAED, because if I understand correctly, you are trying to streamline and develop protocols for the call takers to take to kind of make sure they're getting the right resources to the right place. Is that a correct assessment?
We're always doing that. Yes. I mean, the more, again, it goes back to something we talked about earlier. The development of protocols goes to ensuring that that the protocols are evidence based. We're not going to just throw something out there, but on the other hand, we kind of did when COVID-19 hit.
Mhm.
COVID-19, we had to develop a protocol almost overnight.
Mm.
That was one of, that was one that we didn't have much experience in simply because of the fact, essentially, in EMS, the protocols are developed so that you actually do respond to almost every patient. And in COVID-19, when it was our first experience in developing a protocol that said, you know, don't respond unless you have, it's absolutely a necessity.
Mm.
Consider other treatments, consider other ways of providing that care to the patient. And so our COVID-19 protocol 35, was developed in a matter of days with no evidence base. Now, what's really cool about it is that now it's been studied. There was a study that came out of Northwell EMS in New York that showed that the sensitivity and specificity of that protocol is very, very high. So that made us
Mhm.
kind of happy. That made us pretty damn happy about. I hope I can say that. Okay. That made us pretty happy that we were able to do that correctly and safely for the responders. Um, so yeah, I mean, we're always looking at that. I mean, I think, we've got a new protocol that we just put in place on mental health that completely overhauled or the past mental health um, protocol, and that protocol was done in consultation with mental health professionals. Um, Simply because of the fact that, again, mental health has become such a um, the percentage of mental health patients that are calling 911 is on the rise significantly. And we need to make sure that, we're meeting their needs in a way that, in every way possible in the call center. I mean, a mental health patient doesn't necessarily need to go to an emergency department. There's not much help they can get there. So we need to be able to provide them with the best call taking experience that we can at the time they're interacting with us. Um, and the other one we've just overhauled, we've just completely revised is our childbirth protocol. We did that with a team of nurse experts and midwives in the UK because the midwives are responders in the United Kingdom, and so that's a new to protocol. So I
Hmm.
mean, I can tell you that we are always working to ensure that the protocol is the best it can be and the most evidence-based it could be.
You said something about how you're overhauling the mental health protocol, the childbirth protocol. The thing that came to my mind is, do you get resistance when you're saying, "Hey, I know you've done it this way for X amount of time, but this is what the evidence shows. Do this instead?" Or do people tend to embrace those changes?
No, yeah, I mean, when we talk as the call takers welcomed it
Yeah.
because the protocol was dated, and as far as the
Mm,
community is concerned, the mental health community welcomed it. As far as the
mhm.
callers are concerned, they're not gonna be able to tell the difference because, typically, you only call 911 1 or 2 times in your lifetime. I mean, I know there's exceptions to that. Your listeners are gonna say, "Oh, yeah, well, I've got somebody call us 100 times." Um,
Every
well,
night.
and I get that. When I was in Richmond, I had someone call us 216 times in a year. So I totally totally understand that. But yeah, to call from a caller's perspective, just
Mhm.
providing them with that best experience possible. That's what it's all about.
Well, I would love to just touch on cardiac arrest. I do understand it's less than 2% of the overall call volume or
Mhm.
2.5%, but it's so much of what we focus on in our career. Um, can you talk to me a little bit how your protocols, deal with identifying and being that strong first chain in the chain of survival when there is a cardiac arrest?
Yeah, I mean, the protocols themselves are oriented. Actually, our protocols themselves are oriented in a triage fashion to identify the worst first. Very very
Mhm.
simple. So our way our protocols work is the fact that if the patient is even in some semblance of cardiac arrest, we have a fast track feature that will route that to the telephone CPR. The mean time for our accredited centers, when we capture this data, this is a keystroke data, so we know this for a fact, is about between 27 seconds and 35 seconds.
Mm.
So
Wow.
it's very, very fast. Um, and the other part of this, we now have partnerships with like with Pulse Point, and Good Sam, in
Mhm.
which if those protocols, if those determinants, there's three determinants uh, that will automatically open boxes in front of the call taker to provide them with the location of a defibrillator. So we interface with Pulse Point and Good Sam. It's called a relay. They provide the information to the CAD to a agency's CAD. The CAD then opens it up and interfaces with us with our protocols. And so they're looking at a location of a defibrillator, um, hopefully very, very near to them. Um, and when I say hopefully very, very near to them, our protocol really, um, and we've talked to the experts about this. I mean, we talk, this is physicians, cardiologists. I mean, the fact is, frankly, if it's a one person rescuer, they pretty much need to see that AED. We don't advise going beyond, I think it's either 25 or 50 feet. And for a two person, it's probably going to be, I think it's 125 or 150 yards. I'm sorry, I don't have can't remember the exact distances, but the point here is that, 25 feet or 50 feet, you think, okay, that's not a very far distance. But remember, if it's 25 feet from you right there and you've got to go outside a door, find it, and you're one rescuer, you've completely lost the coronary perfusion pressure for one person CPR in doing that. And so coronary perfusion pressure has to be constant to be able to make sure that that circulation from good quality CPR is being done. Um, so yeah, but the fact of the matter is we do work with Pulse Point. We do work with Good Sam. We do have interfaces, and those interfaces actually appear automatically before the call taker, if it's a cardiac arrest patient and they have Pulse Point or Good Sam interfaces on their computer. And, further, if they hooked up to the internet, they can also launch Google Maps, which will
Mhm.
show where
Mm.
that defibrillator is by lat launch or by a location.
Yeah, and I think that's actually one area of struggle or challenge that we've had in the United States. That in the U.S. there is no official registry, where that's a little bit different in the UK and other parts of the world. Could you speak a little bit to that as far as how AD registries work within the 911 system to be able to provide accurate information?
Rich, I actually don't know that much about you, AED registry. Sorry. I do know. I do know in the UK, you're exactly right. It's very, very. I mean, the registry is done by London Ambulance Services, and it's always updated. EMS is different in the United States in that EMS is local, and we both know that. Your EMS system where you're located is going to be different from Richmond, which is going to be different from Kansas City, which is going to be different from LA.
The old Resuscitation Academy mantra of if you've seen one EMS system, you've seen one
Yeah.
EMS system.
Right, and so I'm gonna be honest, when I don't know something, I don't know it, and I'm not too sure how registries work in the US.
Yeah, I mean, to kind of dovetail onto that, we don't have an official registry. So, a community could set something up where it's just a Google sheet or an Excel spreadsheet of all the ADs that are located in the community, and that may never get updated. It could go a little bit, more advanced, and they, collect a database and have people, submit forms with that information. But if that AD gets moved, if that business goes out of business and closes, if the pads and battery expire, which is something that we know is very common with people not keeping their devices up to date or checking them for readiness, that device, even if it's relayed to the dispatcher, may not be ready for use. So Pulse Point has that AED registry, and I think that's one of the larger ones used in the United States, although not an official one by any means. That has that API that's able to connect with some of the more popular CAD systems and provide some of the information about where the AED is located. Those devices are able to be crowdsourced, but when they are crowdsourced by somebody that's not responsible for it, it shows it as an unverified device versus when an actual administrator is able to, go see it and confirm, yeah, it's there, yeah, it's ready for use. They can check that off as, yep, this is a verified device, and provides that extra kind of level of information to the 911 center. Um, but yeah, it's definitely a challenge, and I think because we don't have an official system in the United States, that just kind of opens it up to extreme variability between community to community.
And, you're exactly right. Frankly, that's always been one of my I'll go off the official IAD mantra here, but going back even to my days in Richmond, I mean, you're exactly right. That's always been one of my concerns about trying to direct someone to an AED, simply because of the fact, is it still there? Or the battery's dead? I mean, what's going on?
Hmm.
I think we've got more sophisticated ways of doing that, like now Pulse Point, and so and we've got good outcomes from that. But the problems you identified are 100% right.
Jerry, I know we are getting close to the end of our time together. I'm curious if there's any, topics we didn't really hit or takeaways you think that the average practitioner could benefit from hearing. Because, like, I could say, as a registered nurse working in the hospital, my knowledge of how 911 dispatch, all that protocols was developed was almost nil. I don't think I knew much more than the average layperson. So I'd love to know if there's anything that you think would be important to share.
I think one of the things that I would like to stress is that in 1991, the first publication of a chain of survival showed that all the links were equal. That link is not equal. There was a evidence-based article published in Resuscitation not that long ago by Charles Deakins that analyzed the different links in the chain of survival by importance and processes. And it showed that early access by far, by far is the most important link. And then telephone CPR was second. So if there's one thing
Mm.
I can stress here is that from, you know, professionally, personally, from my experiences in Kansas City and Richmond and IAD, that we have to make sure we're emphasizing the dispatch center and that we've got to get it right the first time for the call. you know, whether it's our protocols or whatever, there's got to be a structured protocol in place to be able to assure that we're identifying that cardiac arrest patient just as quickly as possible. I mean, our mantra is they don't think they're, you know, we have a phrase about if they're not breathing, you go, period. That's it.
Mm.
Hmm.
We've got to be able to ensure that we're getting hands on chest in absolutely the minimal time. And the only way we can do that is by identifying that cardiac arrest at the point of contact in the call center and ensuring that the protocols, that direct telephone CPR, are the quickest possible way to be able to do that. So, from my perspective, if I'm stressing one thing, is the accuracy of the protocols in the call center to be able to determine what's really going on with that patient and to be able to provide then that best patient care experience. That's the way we're going to save lives. Point
Hmm.
blank. That is the way we're going to save lives.
That's amazing. Jerry, I am so grateful just for not just taking this hour to speak to us, but your dedication, your career, your life work of furthering EMS and saving lives in the process. It's admirable, it's exciting, and I'm honored to have the opportunity to speak to you.
Well, we're just people taking care of people. That's what I like to say. And it's, it's not necessarily admirable. It's just the right thing to do.
I love it. Well, with that, thank you so much for joining us. We are so happy to have this conversation and look forward to being able to speak to you in the future.
Well, I'd like to meet you all both in person very, very soon. So that'd be great.
We'll head over to the UK soon.
Okay. Thank you.
Thank you,
Thank
sir.
you. Thank you.